but the foundation of every successful operation. To remind us of these non-negotiable basics, I invite Dr. Naya Natarajan to share her insights on sterilization protocols.
Yeah, good morning, everybody. Sterilization is a very often neglected topic, not just in PG education, but with most surgeons as well, because it's considered to be very boring. So I have the less envious task of making it interesting today. So this is a picture that you don't want to see on day one post-op of an eye which you have operated, right? And many of us cannot forget the first endophthalmitis that we've ever had. We sometimes even remember the name of those patients. So a million things could have gone wrong. Maybe the patient had an infected lacrimal sac. The OT sister didn't scrub her hands properly. The sterilization of the instruments was incomplete. Sometimes the air in the OT is not sterile enough. But finally, the responsibility lies with the operating surgeon, period, right? So this is a picture of Ernst von Bergmann in 1891 when he used the autoclave for sterilization for the first time. Now, 100 years down the line, we are not, fully sure about asepsis and sterilization still. And this can be because of two reasons. One is ignorance. Science doesn't give us the knowledge completely. And number two is ineptitude, where the knowledge exists, but we fail to use it correctly. So there are two ways or two things that come to our aid here. One is standardization of protocol, and the other is checklists. And I cannot overemphasize the need for these two things in our OT sterilization. And finally, a surgeon himself or herself cannot do everything by themselves. It is a teamwork, and OT sterility is built on trust. So these are the two documents that I would definitely advise every surgeon who's embarking on surgery to read about sterilization. The Center for Disease Control came up with this guideline for disinfection and sterilization in healthcare facilities in 2008, which was recently updated in June 2024, which gives you a complete account of sterilization. And there's another one on guidelines for management of cataract in India, which tells you about, which gives you a sterilization module on cataract surgery. So please do read this for a complete knowledge of it. I'm just going to talk about a few things. Before we go into it, the basic terminology about cleaning. So what is cleaning? Cleaning is the removal of foreign material from objects. It is normally accomplished using water with detergents or enzymatic products. After cleaning comes disinfection or sterilization. Now, disinfection is a process of killing all the pathogenic microorganisms from the surface using chemical compounds like alcohol. But you have to remember that they do not kill the spores. Whereas sterilization is the process of eliminating all the pathogenic microorganisms and spores using primarily heat or steam. Now today we'll be talking on certain things, what a surgeon, as a surgeon, can do to take care of sterilization. So we'll be talking about protocols for operating room sterilization, sterilization of instruments, aseptic protocols for staff and surgeon, and what will you do to monitor and surveil the sterilization procedures. Protocols for investigations and management in a case of endophthalmitis is beyond the purview of this talk, and I will not be talking on that. So a basic idea about the OT layout is essential, and this is because you need to know what are the sterile areas in the OT and what are the unsterile areas in the OT. As much as possible, these two should not cross over, and even the surgeon's entry and the patient's entry should be through different doors. The dirty utility and the clean equipment coming in also should be through different routes. Again, inside the OT, once you are gowned and gloved and scrubbed, gowned and gloved, you should move to the sterile area of the OT, which is the further end, towards the head end of the patient, and you need to remain there throughout when you're performing the procedures. There should be no loitering on the foot end of the patient, which is considered to be the unsterile zone, where the observers and the other people move around in the OT. Now coming to ventilation, many of the OTs are fitted with HVAC systems. But some OTs do have split ACs. Again, they need to be cleaned every month. But what you need to observe here is whether the temperature should be maintained between 20 to 23 degrees Celsius and a relative humidity of around 30 to 60%. And about 15 air changes per hour need to be done. A basic idea, you would have seen all these colored bins in the OT and you don't know which one, what goes into what. Most of the times the sister will tell you, okay, throw it in the red bin, throw it in the yellow bin. But you need to have an idea, a basic idea of where what goes. So where your gloves go, where your soil linen go and all that. So coming to sterilization of instruments, which is the most important. Basically, whatever touches the eye is what is most liable to cause infection, which will be your instruments. The second thing will be whatever goes inside the eye. That will be your viscoelastic or your BSS. Now, for this, you depend on your pharma companies. You have to trust your pharma companies. There's no other way around that. And finally, or the least probably, is the sterile air in the OT, which is not of much concern. But yes, it is also important. Now coming to the instrument cleaning, the first thing is cleaning before going in for sterilization. So cleaning is usually done with the help of an ultrasonic cleaner in which an enzymatic removal agent is applied, or an equally effective method which is used in most OTs is the 4-bowl method, where 4 bowls are taken with distilled water, and in the first bowl a cleaning agent is applied and your instruments are soaked to remove the blood and other debris. And you have to remember that even the cannulated instruments have to be flushed, basically flushed to remove any visco residues or anything. And then it has to be dipped into the other 3 bowls and completely cleaned of any soap residues before it goes into drying and packing. And then finally it goes into sterilization. So autoclaving or steam sterilization is what is commonly used. Of course, it is the most economical. It can be used to sterilize most of the instruments that we use in the OT. It is completely sporicidal and it is not associated with any reactions like TAS. Now, to make sure that the sterilization is complete, we place indicator tapes, which are placed on, I'll be talking a little more in detail when it comes to chemical indicators. They are placed in the bottom, middle, and top of every drum. And the duty of the operating surgeon is to check and sign before you even start your first case in the morning of the surgery. So just for completion's sake, these are gravity-dependent autoclaves. Most of the OTs have these horizontal autoclaves or the vertical autoclaves. Basically, what is done is steam is put into the, pumped into the chamber, which will push the air out. So it takes some time for the air to completely come out. And then a temperature of around 121 degrees Celsius is achieved for about 30 minutes at 20 psi. So this is the usual steam sterilization that is done. You have a quicker way of doing it, and this is called as a B-class autoclave. The only additional thing that it has a pre-vacuum setting. So it will remove all the air automatically. So obviously the autoclave time comes down to around 4 to 5 minutes, which is much more easier. When you have to do sterilization between the surgeries, that is, you have an instrument which you need to reuse, you don't have enough sets, then you go for what is called as a flash autoclave. Now, flash autoclave has a cassette basically like this, so all the instruments don't have to be wrapped, only cleaned and dried and put in this, and then in 7 to 8 minutes your sterilization will be done. Now coming to ETO, or ethylene oxide sterilization, this is done usually once a month or twice a month in most OTs. Those instruments which have wires on them, like your diathermy probes or cryoprobes, these are the instruments which can be autoclaved with ETO sterilization. So the instruments are packed in special polythene bags with indicators inside, and you have to remember that this ETO gas is very toxic, so aeration period of minimum 72 hours should be there before you use these instruments. So the thing to remember here is that autoclaving in drums or linen, the shelf life is just 48 hours. Whereas if you autoclave with double packing, like in a B-class autoclave, then you can keep it for around 28 days. And ETO sterilization with a double packing usually can be kept for a year. Now this is what I would like to stress today, aseptic protocols for the staff and surgeon. So separate OT scrubs in the OT. No scrubs that are used in the OPD or anywhere else should be used in the OT. No street clothes, and of course no wearing warmers inside because woolens will attract microorganisms. Well-fitting scrubs, no flapping, and you should have dedicated OT slippers or shoe covers. While wearing the cap and the mask, the cap needs to cover all your hair completely, and the mask needs to cover your mouth and your nose also completely. Decontamination of hands is a very important way of stopping infection from happening. So the scrub time should be minimum of 5 minutes. The first wash should be with soap, and the second and third wash with an antimicrobial solution like povidone 10% or chlorhexidine 4%. The areas in red that are marked over there are probably the areas that will be most missed when you're doing a scrubbing. So this kind of a chart should be ideally put up, and please, most of the OTs have that next to your scrub area. You need to keep looking at them and make sure that you don't miss any of those areas and scrub all the parts. And you should remember that your hand is the most sterile part. Okay, so your fingers and your hand are the most sterile part. Everything else is less sterile. Up to your elbows is less sterile. So another thing, after scrubbing again, when the water is poured, again it has to go from the most sterile area, which is your hand, down up till your elbow, not the other way around. So that is important. So make sure you take it out of the stream of water and then again go ahead and wash. This is a video of gowning. So again, in gowning, it's very important that you push your hands both into that and not pull it like this. That's wrong. Okay, so your bare hands, ideally, after you go into the gown, should not be touching anywhere else. You just pull it, and most of them have elastics here, so you can easily pull it and it won't come down. And you have to remember that anything below the waist and behind you is completely unsterile. It's considered unsterile. So as soon as you finish gowning, you need to put your hands up and hold it in this praying mantis position and not let it loose or hang down. Again, donning gloves. After I finished undergraduation and in post-graduation, I remember when I was wearing gloves, one of my professors asked me to, he saw me wearing the glove and he asked me to wear it again. So I had to, take it out and again wear it. I did it 3 times to get it right. So I will never forget how this is done. So when you put the first glove in, you're using your bare hands to put it in, right? I'll show you this again. So you're using your bare hands to pick up the glove. You're putting your first glove inside. So you're holding the inner surface of the glove and not the outer surface. You're not touching the outer surface of the glove. So once you pull it in over your band there, you'll use the sterile part of your left hand glove now to hold the outer part of the glove. You're not touching the inner part of the glove again. You will go in and you will pull it, so you're nowhere touching the inner part of the glove here. And you will pull out the other side. Again, you're touching only the outer side here. So this is the correct way to wear your gloves. Again, removing gloves is again important. The outer part is now completely, you've got blood, you've got everything, so please don't touch anything. You need to make sure that you remove one of the gloves holding from inside, hold it in the other hand, and then pull the other one out and throw and wash. So during surgery, you need to double check orally the sterility of the opened consumables. Most of the times, the date is written, so you need to confirm once before using the instrument. And if there is an accidental touch, by chance you touch something that is unsterile, don't be scared of the sister. Please tell them, don't hesitate to change your gloves. And if there's a need to cough, please turn away from the operating area and cough. Now, between cases, this is a very nice way of, waiting, but this is absolutely wrong because your elbows, again, are considered unsterile. So please don't stand like this. You change your gloves and you hold your hands in praying mantis position and stay in the sterile zone, and there should be no loitering. For observers in OT, hands are kept, these are some of the rules that we follow. Hands are kept together away from any equipment. Leaning or crossing or touching over the sterile fields is not done. And 1 foot clearance from the sterile area should be strictly observed. And excessive coughing or sneezing inside the OT should be avoided. But nowadays, with these days of 3D microscopes and other things, it becomes very easy. You just wear a 3D glass and then you can stand very well away from the sterile field and watch everything in detail. So coming to monitoring and surveillance, the last part of the talk, surveillance of sterilization procedures. This is what most of us neglect. We don't know much about it maybe. Most of us neglect this. So there are air conditioning units and HEPA filters which need to be checked routinely. Water samples need to be taken and tested. OT culture needs to be done periodically. Autoclave and ETO has to be validated regularly. Now all these dates ideally should be displayed prominently outside the OT somewhere on a board for everyone to see. So even before you enter the OT, it is better to have a look at it and make sure that you're going into a validated OT before you start the OT. And OT swabs ideally should be sent for biological testing every month. They should be taken from both sterile and unsterile surfaces. So the floor, the OT surfaces, wall, AC unit, everything. Air samples also need to be checked by an open dish sedimentation method. And again, the due date needs to be noted and displayed. So coming to sterilization validation and indicators, this is called as the Bovie-Dick test. It is used to detect inadequate air removal or air leak inside the sterilizer. So this is a set of towels which are like 100% preconditioned towels which are placed inside the OT, and about 3 minutes inside the sterilizer, the autoclave, and the autoclave is run for about 3 to 4 minutes, and if it shows a uniform color change, then it is good to go. This ideally needs to be done before using the sterilizer every day, but generally not done. Usually a weekly once this is done, the Bovie-Dick test is done. Coming to chemical indicators. Now this is what you generally see on the bins. So the chemical indicators are of 5 classes, but what we generally use are the class 1 and the class 5 indicators. Now class 1 is a process indicator. It will only tell you whether the unit has been exposed to the sterilization process, nothing else. Whereas a class 5 indicator will tell you whether all the variables like temperature, pressure, time have been achieved, and they can be counted equivalent to biological indicators, which are the gold standard of sterilization. So this is a class 1 indicator. You can see on the top picture that it is not yet done, and then there is a color change down, so it is done. So it has been exposed to the sterilization process, but it does not give you any idea about the biological load. So class 5 indicators which are placed inside the bin, inside the set are more important, and they should be removed and dated after sterilization and displayed in the logbook, and the surgeon needs to look at this and sign before the first case of the day. Biological indicators are used both for autoclave and for ETO sterilization. Now these use the spores of bacillus basically, and if nowadays you have these rapid readout ones where there's a color change immediately and you know that the spores have been killed. So this is what has to be done every fortnight, and the results must be documented. This gives you a better idea that the sterilization apparatus is working correctly. Now, when it comes to when you have an endophthalmitis, it should be ideally told to an infection. Immediately, an infection control committee has to take care of it, which is a team comprising of the ophthalmologist, the nurse in charge of the OR, the hospital manager, and the lab in charge. So in case of an infection, it is brought to their notice immediately, and immediate investigation and a complete repeat validation of sterilization procedures before restarting the OT has to be done. So the take-home message is that sterilization practices need to be practiced meticulously. The SOPs, the standardization of protocols and checklists, will form a very important part, and teamwork and understanding each member's role is very, very important. Thank you.
Thank you, Dr. Maya, for reinforcing that a checklist. It is a culture of for every